Hello, and welcome to Learn from the Case. Today, I want to awaken your curiosity with a new neurological case. I want to talk to you about stroke. I prepared a presentation in 4 parts. This is part 3 of 4 of them. I present some cases and make a first approach to the issue of a stroke. So, let's see different strokes depending of the affected vessel. The medial cerebral artery is by far the largest cerebral artery and is the vessel most commonly affected by cerebrovascular accidents, typically present with the symptoms that individuals associate most commonly with strokes, such as unilateral weakness and/or numbness, facial drop, speech deficits ranging from mild dysarthria and mild aphasia to global aphasia. The symptoms will depend on the extent of the infarction and the site and level of vessel occlusion. Now let's see the anterior cerebral artery. Strokes in the anterior cerebral arteries are uncommon, less than 2 to 5% of all strokes. And you usually can see dysarthria, aphasia, unilateral contralateral motor weakness, legs, shoulder, arm, hand, face, minimal sensory changes, 2-point discrimination in the same distribution as above, left limb apraxia, urinary incontinence. Here I want to say that limb apraxia differs from other motor disorders in that it occurs most commonly following damage to the left rather than the right cerebral hemisphere, and deficits are observed in both limbs, hands and legs, from the same side, following left hemisphere damage. Now we move on to internal carotid artery infarction. Internal carotid artery infarction causes acute hemispheric hypoperfusion that can manifest as seizures, contralateral limb shaking, or hollow hemispheric, blurred vision or vision loss, confusion, memory loss, typically for recent events, numbness or weakness in one side of the body. Occasionally, and especially in the presence of a robust circle of Willis, occlusion of the internal carotid artery spars the anterior cerebral artery and produces a clinical scenario indistinguishable from branch medial cerebral artery infarction. If collateral flow across the posterior communicating artery, anterior communicating artery, or PL arteries is adequate, the occlusion can be clinically silent or only affects smaller susceptible areas. By contrast, with pure collateral or a distal internal carotid artery in T occlusion can lead to catastrophic hollow hemispheric infarction with a sparing of only the posterior cerebral artery territory, thalamus, and medial temporal and occipital lobes. Now let's see border zones or watersheds infarcts. These are ischemic lesions that occur in characteristic locations at the junction between two main artery territories. These lesions constitute approximately 10% of all brain infarcts and are well described in the literature. Differentiating between internal border zones and perforating artery infarcts is important, because each may arise from different mechanisms, namely carotid disease and small vessel disease, respectively. Superficial border zone infarctions occurs high along the convexity of the corona radiata between the deep and cortical structures between arteria, cerebral anterior, and medial cerebral artery territories, or posteriorly between the medial cerebral artery and posterior cerebral artery territories. This pattern of infarctions occurs when collateral flow is able to supply the majority of involved territories but is unable to meet completely between territories. Resulting symptoms form a combination of weakness, sensory loss, and cortical signs. Transcortical aphasia of the expressive or receptive type with relatively preserved ability to repeat is also common. Anterior cerebral artery and medial cerebral artery watershed infarcts primarily cause arm weakness because the affected region corresponds anatomically with neurons of the motor strip that innervate the upper extremities. When bilateral, as occurs with cardiac arrest, anterior cerebral artery and medial cerebral artery watershed infarctions result in Manning-de-Barrel syndrome, characterized by proximal bilateral arm and or leg weakness, with relative preservation of facial and distal extremity strength. Internal border zone infarct or a subcortical junctional infarct occurs, for instance, for total internal carotid artery occlusion or with large medial cerebral artery branch occlusion. Non-collateralized deep penetrated artery that descend from the cortex to the lateral wall of the ventricles represent the most hemodynamically vulnerable distal field in this scenario. The result is a pattern of multiple small deep infarcts involving the deep white matter of the corona radiata and centrum semioval. Internal border zones infarcts had a higher frequency of severe carotid stenosis and occlusion, diabetes mellitus, and heart disease. Anterior choroidal artery is the last branch of internal carotid artery, originating just proximal to anterior cerebral artery, medial cerebral artery bifurcation. It supplies blood to internal capsule, lateral thalamus, and lateral geniculate body or optic radiation. An infarction there would result in contralateral hemiparesis, hemianesthesia, and homonymous hemianopia. Now we move on to posterior cerebral artery. The infarction of the posterior cerebral artery will cause hypoperfusion in occipital and inferior temporal lobes. The usual presentation is sudden onset of a contralateral homonymous hemianopia. Bilateral occipital lobe lesions can cause Anton or Anton-Babinski syndrome, cortical blindness, and recognized by the patient. Charles Bonnet syndrome or release visual hallucination can also be seen in cortical blindness from bilateral occipital lobe injury. Valent syndrome is seen in bilateral parieto-occipital junction infarcts, and it's characterized by simultanoxia, that is, the inability to perceive parts of an object as a whole. Oculomotor apraxia, incoordinations of gaze, and optic ataxia, poor hand coordination during visual guidance. Hemi-neglect, although uncommon with occipital lesion, can be seen when the injury extends to the parietal lobe. Hemi-neglect is the inability or difficulty to detect, attend, or to respond to stimuli present to the opposite side of the lesion in the absence of sensory and perceptual problems. Left posterior cerebral artery infarct can cause alexia without agraphia, which is a type of disconnection syndrome between the non-dominant occipital cortex and the language processing area in the dominant parietotemporal cortex. Inferomedial temporal lobe infarction may cause agitated delirium or global amnesia. Proximal posterior cerebral artery infarction affecting the thalamic perforating arteries will lead to infarction of the thalamus and midbrain. If the vertebral posterior nucleus is affected, the patient will have contralateral hemianesthesia. Hyperpathia may subsequently develop in a condition called Disherin-Rossi or thalamic pain syndrome. As the thalamus serves as a relay to the cortex, thalamic infarction can also cause a variety of atypical symptoms such as ataxia, aphasia, if the dominant hemisphere is affected, hemi-neglect, if the non-dominant hemisphere is affected, visual field deficit, memory loss, or behavioral disturbances. Lethargy or coma can result if the reticular activating system in the midbrain or thalami is affected and will often be accompanied by a combination of oculomotor abnormalities. Alterations in consciousness are especially common in the presence of an anatomically variant artery called artery of Percheron, which supplies the bilateral medial thalami and rostral midbrain from a single vessel, originating on an unilateral posterior cerebral artery. See the picture here. Midbrain lesions, when posterior, cause Perinaud syndrome, characterized by sustained conjugate downgaze, upgaze paralysis, converge or retraction nystagmus, lid retraction or Collier sign, and pupillary light neurodissociation. Now let's move on to vertebrovascular territory infarction. The basilar artery is the main conduit to supply the posterior cerebral artery, both of them. Vascular thrombosis can manifest with a combination of medullary, pontine, midbrain, and posterior cortical signs. Basilar thrombosis leading to infarction of the anterior pons bilaterally causes lock-in syndrome, complete bilateral face, arm, and leg paralysis with isolated preservation of vertical eyes movements and preservation of consciousness. Infarcts resulting from small vessel thrombosis of the pontine perforating arteries cause a combination of cranial nerve dysfunction, long tract signs, including weakness, reflexive posturing, or hyperreflexia, sensory loss, and or cerebral findings. Small anterior pontine strokes can also produce lacunar syndromes without cranial nerve deficits, and so is clinically indistinguishable from anterior circulation lacunes. Oculomotor or gaze palsies, including internuclear ophthalmoplegia and skew deviation or nystagmus, are also common. Top of the basilar syndrome refers to occlusion of bilateral distal basilar and proximal posterior cerebral artery, thalamic and midbrain penetrating arteries from embolism. The result is a pattern of bilateral small vessel infarcts involving the midbrain and thalami, with asymmetric vertical gaze abnormalities and skew deviation, changes in level of consciousness, and variable bilateral motor and sensory deficits. Infarction of the lateral medulla occurs when the posterior inferior cerebral artery of a branch of the vertebral artery is affected, what results in a lateral medullary or Wallenby syndrome, which is characterized by vertigo, ipsilateral ataxia, loss of pain and temperature sense in the ipsilateral face and the contralateral arm and leg, dysphagia, and ipsilateral oculosympathetic syndrome or Horner syndrome. Now the case for this video. A 49-year-old chronic alcoholic hypertensive Indian male presenting with sudden onset of breathlessness at rest for 5 hours and associated with palpitation. The patient presented via ambulance in the emergency department. The patient was found to be in acute left ventricular failure. There was no history of trauma, fever, cough, and peripheral edema. On admission, a high blood pressure of 220 over 140 millimeters mercury. The normal blood pressure should be under 140 over 90 millimeters of mercury was observed. Shortly, he had sudden cardiac arrest, from which he was resuscitated after 15 minutes. Epinephrine was administered continuously as an intravenous infusion, 1 milligram every 3 to 5 minutes, and anti-edema measures like furosemide, 1.0 milligrams per kilo intravenously was injected slowly to prevent the progression of pulmonary edema. He required ventilatory support and remained unconscious and in shock for about 2 hours. The blood pressure improved to 100 over 70 millimeters mercury. The next day, post-cardiac arrest, after regaining his consciousness completely, the patient complained of proximal upper limb weakness in the form of difficulty conducting his arms. Neurological examination, he had normal consciousness and normal speech. His cranial nerve examination was normal, with normal bilateral funding and no facial weakness. Upper limb examination presents as reduced tone, and according to the Medical Research Council, the power of proximal muscles was 3/5, with increased deep tendon reflexes and spasticity. Distant hand motor functions were normal with a normal sensory examination. Lower limb examination was unremarkable, with normal bilateral flexor plantar response and normal sensory examination. Chest X-ray was suggestive of cardiogenic pulmonary edema. ECG showed Q waves with V3, V4, V5, and V6, suggestive of myocardial infarction. Two-dimensional echocardiography showed regional wall motion abnormality in the anterior wall with dilated left atrium and ejection fraction of 33%, without the evidence of intracardiac thrombi or valvular dysfunction. A plain MRI of the brain revealed hyperintensity areas between a bilateral anterior cerebral artery and medial cerebral artery, suggestive of watershed infarcts. Carotid artery Doppler sonography was performed in bilateral carotid arteries and exclude carotid artery stenosis. You see the MRI with the watershed infarcts. Blood investigations were performed to rule out other comorbid conditions, and the anticoagulation profile was normal. Liver function tests were suggestive of ischemic hepatitis. This was a case of myocardial infarction with hemodynamic cerebral infarction with man-in-the-barrel syndrome. Here I leave the link in case you want to read the case yourself. See the description of this video. We leave here for now. Thank you for your attention, and I invite you to see the first and last part of this presentation in the next video. Be well.